feel like I'm knocking on heaven's door. I'm knocking on heaven's door. I'm knocking on heaven's door.
All right, Mr. Collins, it was 113/85, okay? It's pretty good. Feeling okay?
Oh yeah.
Have any pain or anything? On a scale of 0 to 10?
0.
0? Okay. Well, I'm gonna start getting ready to go. So I'm gonna go give a report to your new nurse, and then we'll be back in to check on you, okay?
All right.
All right.
Thank you.
Yeah, call me if you guys need anything, okay? Thanks for everything. Room 777. We have a 93-year-old male, initials JC. His full name's John Collins. Came in with shortness of breath, chest pain, and increased temp at 99. He's alert and oriented ×3. I just took his vitals. His BP was 113/85. His heart rate was 90. SpO2 at 95. He's on 2 liters of oxygen through the nasal cannula though. Respirations are at 20. He has a history of hypertension, falls, right-sided weakness related to stroke back in 2012. He has diabetes type 2. He has bilateral wounds on hands and feet. I have Zosyn running at 12.5 in his right hand.
When is that due to be done?
It is due in 40 minutes.
Okay.
His CO2 levels were a little low. They were at 31. And his WBCs were high at 13,000 when the labs came back. He had 2 milligrams of morphine for pain 30 minutes ago. It's due PRN every 3 hours. And that's about it. Any questions?
Nope, I think that's all.
Okay, great.
A patient can deteriorate very rapidly, sometimes occurring as fast as over minutes or hours. Common changes in the deteriorating patient one can expect are change in heart rate, a change in level of consciousness, a change in oxygen saturation, respiratory status, decreased urinary output, and sometimes just the patient not looking quite right.
Hi, John. I'm Miranda. I'm going to be your nurse today. Can you wake up? Can you tell me your name?
Robert?
Do you know where you are right now? You're in the hospital. You were having some trouble breathing earlier and some chest pain. They brought you in. Are you the son?
Yeah, I'm Joseph.
Has he been like this all day?
No, I went downstairs to get a cup of coffee and came back and I found him like this.
Okay, I'm going to take a blood pressure real quick. I'm actually going to come over here.
The Rapid Response Team, or RRT, is often called when a patient demonstrates signs of imminent clinical deterioration. The team consists of medical professionals who are summoned to the bedside to immediately assess and treat the patient with the goal of preventing ICU transfer, cardiac arrest, and/or death. It is called for patients who deteriorate acutely, often exhibiting warning signs such as a heart rate greater than 140 or less than 40, a respiratory rate greater than 28 or less than 8, a systolic blood pressure greater than 180 or less than 90, oxygen saturation less than 90, acute change in mental status, and a urine output less than 50 cc's in 4 hours. The major distinction to be made between the Rapid Response Team and a Code Blue is that the Rapid Response Team is called before the patient enters respiratory or cardiac arrest, whereas the Code Blue occurs afterwards.
Okay, I don't like the way his vitals are looking right now. His blood pressure is a little low and his pulse is actually pretty high. I'm gonna call what's called a rapid response team on him, and they're gonna come in and check him out a little further and make sure everything's okay. I'm actually gonna have you step out because it's gonna get a little hectic in here. There's gonna be a lot of people in here, okay?
Oh, okay.
When the nurse discovers a patient that may be in need of a rapid response team, the first priority is to assess the patient. If the need is uncovered to call for a rapid response team, when calling for help, the nurse should identify themselves and identify the patient with the room number. The first responder is to stay with the patient at all times. Pertinent information can be shared with rapid response team members upon their arrival to the scene.
Hi, this is Miranda on the 7th floor. I'm the nurse for John Collins. I need a rapid response team up here in room 777 as soon as possible. Thank you.
The rapid response team often consists of many medical professionals such as critical care nurses, respiratory therapists, and physicians or nurse practitioners. Roles of the critical care nurse include administering medication, documentation, and conducting assessments.
Hi, Miranda. So what's going on right now?
This is John Collins. He came in a couple hours ago with shortness of breath and chest pain. He was also showing signs and symptoms of infection. I came in about 10 minutes ago for my shift, and I noticed that he was a little diaphoretic. He was very disoriented. So I took a set of vitals, and his heart rate was in the 140s. His respiratory rate was 30. His blood pressure was 80/42, and I also noticed that his oxygen saturations were dropping. The lowest I saw was 83, and I got a temperature which was 102.
Okay, Eric, let's start a bolus. Miranda, can you get another set of vital signs?
Sure.
I'm gonna lower down the bed.
How was his breath sounds?
Alex, can you
They were clear but a little diminished.
start some oxygen on him? Can you turn it up to about 8 liters?
Yep. Yeah, the breath sounds are still diminished.
John, hey. I'm Dr. Jesse Rosen. How are you feeling?
His blood pressure is 70/54.
John, can you tell me where you're at? John, wake up.
Yes.
When was his
Hi.
last blood sugar?
I'm
I
Dr.
haven't gotten one
Rosen.
yet.
Hi. How are you feeling today?
Want to get a blood sugar?
Alright, his eyes are rolling back. His pupils are fixed and dilated.
His blood sugar is 210.
210?
His O2 saturations keep dropping.
What is it right now?
82.
Alright, I'm gonna need a stat ABG, electrolytes, gonna need serum lactate. Oh yeah, and Miranda, can you hook up the 12 lead
Yes, sir.
EKG, please? So the bolus is started, you got the oxygen on. Okay.
Oxygen's on 15 liters. Do you want any kind of freezing treatments on him or anything?
Yeah, can we get a albuterol and a nebulizer.
Okay.
What's his oxygen at right now?
It's still in the 80s. John. He's still breathing pretty heavily. John, hey, can you squeeze my fingers for me?
Okay, the bolus is done. I'm gonna take vitals again.
I'll check his temperature. Hey, John. John, can you hear me? His temperature is 101.4.
His blood pressure is 90/50.
Okay, it seems like he's stabilizing a little bit, guys. Let's go ahead and transfer him down to an ICU.
Okay, I'll go talk to the family.
How's my dad doing?
He's stable for now. We gave him some fluids. His blood pressure come up a little bit. The doctor wants to transfer him to the ICU. So when I find out the room number, I'll take you up there. The doctor's gonna come in and talk to you a little bit about your dad's care and what you want to do. So he'll be in a little bit to talk to you, okay?
Okay.
Do you need anything right now?
No, I think I'm good right now.
Are you sure?
I'm pretty sure.
Okay.
Healthcare power of attorney is a type of advance directive for healthcare. It is a document that allows an individual to appoint a person or organization the ability to manage one's affairs if they become unable to do so themselves. It grants the agent or the power of attorney the authority to make medical decisions for one if they become unconscious, mentally incompetent, or otherwise unable to make decisions for themselves regarding medical care. There are currently 3 code statuses that apply in the state of Ohio, the first of which being full code. This means that measures will be initiated to intercede if the patient experiences respiratory or cardiac arrest. These patients have no limitation on their care, meaning that they will receive any life-saving measures such as defibrillation. The next is the DNR-CC for comfort care. The DNR protocol is activated from the moment the DNR order is issued and signed. This patient will only receive care that promotes or offers comfort, such as the treatment of fevers, pain, and other causes of discomfort. The DNR-CCA, or comfort care arrest, is the DNR protocol that becomes active only once the patient experiences cardiac or respiratory arrest. These patients are treated as a full code patient up until the time that the patient experiences respiratory or cardiac arrest.
Hi, Joseph. How are you doing?
Not too well. Doesn't look like Dad's doing too well.
Yeah, we have him down in ICU right now. He's pretty stable. I'm Dr. Rosen, by the way. So we transported him. He's down there right now. We upstairs, he was going through a little bit of septic shock, probably most likely from his infection. He had a low blood pressure and elevated temperature up there. So we also gave him a fluid bolus and oxygen just to kind of hope bring his blood pressure back up and hopefully stabilize him. So right now he kind of is deteriorating a little bit. Are you the power of attorney by chance?
Yeah.
You are? Okay, perfect. So with you being a power of attorney and him not being able to pretty much answer any questions or make any decisions about his health, I'm going to talk about some of the code statuses that we may need to change your father to. So that's your choice, but if we do need to intubate him, do you know if your father...
No, he wouldn't want that.
No.
He's had a good 93 years. His quality of life's going down.
Okay.
There's no point in dragging it out.
Okay. So there is a code status that we use here. That's actually 2 of them. The DNR-CC, which is comfort care, or the DNR-CCA, which is the comfort care and arrest. So with the DNR-CC, to help improve, as he's deteriorating, to improve the quality of his life, we give him medication to control like his fever or pain. So that's just comfort care. until he dies. And then with the DNR CCA, we do everything we can until he goes into cardiac or respiratory arrest. So would you like a little bit of time to think about changing his status at all?
No, I think I can make the decision now.
Okay, then what would you like to change his status?
DNRCC.
Okay, so we're going to do comfort care. So you do understand that we are just going to keep him comfortable with medications, oxygen.
Yeah.
Okay.
I just don't want a tube down his throat.
Okay, not a problem. I will make sure of that. Okay, and if you could just sign right here on the X. All right, perfect. All right, Joseph. So I will keep you updated on one of the nurses on the floor to keep you updated. Okay.
All right, thank you.
Have a good one.
Okay, is there anything I can do for you?
No, I'm just gonna spend these last few moments with my dad. Nurse! Nurse! Is he dead?
There's no pulse. Your dad has died. Alright guys, we're gonna call it at 11:24. Sir, I'm sorry for your loss. Is there anything that you need us? Would you like to talk to the minister or anybody?
No, I think I just need to call my family.
Okay, we'll be here if you need us, alright?
Thank you.
After a patient dies, nursing care continues as physical care of the body as well as emotional care of family members. Respectful and dignified care after death that is sensitive to the needs of the family is to be provided. Nursing responsibilities include preparing the patient for viewing by the family, which entails bathing, positioning, and cleaning the environment around the patient, ensuring that proper identification of the patient is in place prior to transport, which usually involves a tag on the chest and the great toe. The nurse is to communicate with the family, helping them with the grieving process in such a difficult time after the loss of a loved one. The nurse is to arrange for any spiritual care that is desired by the family, such as pastoral services. The nurse may also advise or assist the family regarding the following topics: obtaining a legal pronouncement of death, transportation of the patient to a morgue or funeral home, notification of the patient's extended family or friends, handling the patient's belongings, and arranging funeral or cremation services for the patient. Breaking the news of death is commonly cited as one of the most stressful and sensitive tasks that a nurse may perform. Best practice for breaking the news of death to friends and family of the patient includes a doctor or nurse who is familiar with the relatives breaking the news in a non-clinical private area which can be used by relatives as long as they need, face-to-face or in person rather than on the phone. The person telling the family of the death should avoid euphemisms such as passed away. Dead and died should be used and repeated several times throughout the conversation. If the family desires to know such information such as diagnosis, treatment given before death should be given, and an offer of support should be provided to the family. Be prepared to respond to feelings and prepare relatives for what is expected of them after they leave. Give the family time to ask questions and answer all questions honestly and accurately. If the family is not at the hospital during the time of death, families should be contacted regarding a change in patient status and encouraged to come to the hospital. If they inquire about the death of their family member on the phone, the truth must be told. Emotional support and offering of self to the grieving family is a priority nursing intervention after a patient death.
Hi, Joseph. I know this must be a tough time for you, but if there's anything you need to talk about, I'm available for you to talk to. Do you want to discuss anything right now?
No, I think I got it all figured out.
Okay. We are available to help you contact any family members. Do you need any help?
No, I got a hold of my sister. She'll be in town tonight.
Okay, I just want to offer you that we also have pastoral care here. We can contact any priests, things like that. You need help?
No, our family reverend's gonna come in.
Okay, and then also we can help you transporting your father to the funeral home or anything like that. Have you figured anything out, or do you know?
Yeah, I called them earlier. They said they'd come later today to pick him up.
Okay, you can take as much time as you need with your father. We're here to help you if you have any questions or concerns, so don't hesitate to ask.
All right, thank you.
No problem.
Two, three.
Don't count. Okay, wait. All right, I'm go.
Okay.
Action.
Action.
I'm looking for that.
Yeah, maybe not.
I'm gonna knock on the door. Do not open it.
What's up, dude?
Okay.
You opened the door when we specifically asked you not to?
I literally said do not open the door. Can you squeeze my hands? Can you wiggle your toes? Now what?
No, I can't do it.
Let's do it again.
All right, you guys. This is third time's a charm.
I'm gonna ask you.
Hey, Brenda.
Hi.
Blood sugar's 80 over 45. Or blood pressure. ECG. What are we supposed to do?
Hey.
Get out of here. Hey. Seducing me?
Hey, baby.
Are you Dr.
You don't have to knock.
So what that is if he does go into a situation where
That way.
That way.
that way.
So what made you want to get into the industry? Okay, all right.